I'm just going to wait for Melissa, who actually put together this slide program, because she's going to help us today also. So if we could give her a minute and then we could get started. What do you think, Kerry? I sent an email to Melissa. I'm not sure if she's having an issue or not, but do we want to get started?
I think in the interest of everyone's time, we should go ahead and get started. I don't know if anyone else is expected. I haven't, Stephanie Ross, I haven't heard from them.
Ross texted me he can't join. He was going to be going in person too, and Stephanie also, but they neither one could join. That's why I kind of changed it, and I so apologize to everyone. When the numbers started getting less and less, and it's hard for me to see. I know that's Karen there. I can't get it any larger. There's someone with Karen.
Brian Cornier is also in the room.
Oh, hi. I apologize to both of you. I was hoping that everybody would have gotten it before anyone made the travel, but we had started out as 5 or 6 in person, and then we were down to 3. So I thought maybe, as much as I love to be in person, that I could have saved everyone the trip, but clearly I didn't catch everyone, so I apologize. Okay. So I'm hoping that everyone received the PowerPoint, if we want to call that, about the working group that was put together by one of our volunteers at Regional Hospice, who does such a phenomenal job of kind of consolidating minutes and giving us a real good summary of all the things that we talk about at our meetings. And so I asked her to do the same thing for us. Her name is Melissa. I know she's not on here yet, but she was able to put this together. I don't know if everyone got a chance to look through it, but it just kind of helped me to figure out where we are to date. Like the things we have talked about, the barriers that we've talked about, any topics or issues that we really should be focusing on, And I was hoping, I spoke to Kerry before, and I think what we're both kind of hoping for today is that we can really start setting the agenda or developing a flow chart of what it would look like. And I know sometimes we say, well, that's a, Department of Health thing, or that might be a federal issue. I think everything goes on the table. And even if it's a federal issue that might need to be dealt with, I think we need to put it in our recommendations, because if we really want to provide pediatric palliative and hospice care the way we know it should be, then that's where a change or two might need to happen. Maybe that is, there she is. Hi, Melissa. I was just telling everyone about the how good you are at helping gather, listening to all the thoughts and kind of putting them together and giving us the great sheet the great PowerPoint that you did. And I invited Melissa today because I think that as we talk about what we really want to put in the recommendation, whether it be far-fetched or low-hanging fruit, she can kind of develop that flow, that flow analysis for us. And kind of, we can see where we hit the barrier, and then a yes or no of how we can possibly, change it. Does everybody kind of agree with maybe that's where we can be going today? Okay, I see. Good. I see heads shaking. Yes. So Kerry, if I can throw this to you only to kind of start us off with, okay, we have a child who is, has complex, whether it be, chronic illness, end of life illness, however we want to describe it, they present. And then where do we go from there?
So what would that look like from a home standpoint, right? But the question is, so
Correct.
we have a patient. Okay, so let's use a patient that's currently on my census. So we'll just call her Betsy, but that's not her real name. So Betsy's
Okay.
here and she has a brain tumor. She presented to us 2 days ago with altered mental status and worsening evidence of her glioblastoma. So she is 15 years old and she resides in a part of the state that doesn't have traditional resources right now. She's going to continue with chemotherapy, but we'd really love to get her home with the necessary things she needs in terms of DME, the necessary medications, and an opportunity to have eyes in the home that can help support them. Because she is just progressing, the family's not quite ready to engage the concept of hospice, but would love palliative care support in their home, which we can talk about the fact that it's sometimes hard to transition to hospice. Remember, with concurrent care, she would qualify for hospice care, but we're really trying a new medication, a new chemotherapy. We're really hopeful for time for her. And so we are ready to send her home, and we need an agency that's going to accept her. We need, for the skilled nursing, we need the DME to come through either insurance or through other resources. And we need her medications to be delivered to the home. We could at some point need assistance with transportation for her, depending on the complexity of her symptoms. We could be to continue her medications. And ultimately we will, without question, likely be transitioning to more of a hospice mode where we need more support at home so that she can pass at home at some point.
Okay, so kind of what we're hearing is that, and maybe this could be a high percentage of kids, is that it could be starting with a home care perspective, right? Home care nursing, which would be your general home care agency.
Correct.
Okay. And that would mean that they would get palliative care on top of that?
So our hope would be that palliative care would be that service provider for
Palliative
them,
care would
right?
be that
Our
service.
hope would
Okay.
be that we will, so because she's 15, she may qualify for an adult service opportunity currently, but our hope would be that she would have the opportunity to receive services in her home for all of those needs to assist with coordination. But honestly, the greatest role with services in a home is to have a contact in the home to prevent unwanted emergency room visits, to prevent, right? Because if your eyes and ears are all dependent on who's on call in the oncology clinic, you may not get the same resources if you have a palliative care provider in the home. They can help with some of those decisions as we transition to more of a hospice model.
Okay. If, and I understand what you're saying, and anybody please jump in at this point, because you all know this from different perspectives. So if we were to say, and like you said, they're not exactly ready for a hospice model, maybe they're not there yet, but they would like the care to help them in the home, extra eyes and ears in the home. And they really would need, I mean, right now, from my understanding of palliative care, it's not consistent visits in a week perspective, like they're not getting, so it would be palliative care so that you're not doing those hospitalizations, so to say, if you don't want to, but you need nursing in the home, some kind of consistent nursing.
You need correct. I mean, nursing is the tip of the iceberg, but you need nursing. And then ideally, I mean, this is, there's a 15-year-old that's probably going to have an exploration of faith that occurs at some point, right? This particular family is Catholic at base, but they may need faith support services. But the beginning ask, for me to feel comfortable with her at home is to have eyes and ears in the home and capability for medications and support and DME products. That's kind of that's the first line. And then the second line is we would love PT in the home, right? This child's mobility is going to be based upon the quality of support services she receives. And so those kinds of things as well. So if you're asking me what we would love for this family for success for whatever time this child has, those are the components that come to mind first.
And usually with traditional home care, they could provide PT, any of that with your traditional home care.
Sometimes
as I know it, but you have to tell me more.
Yeah. So home care does not always guarantee in-house PT, because in-home PT sometimes is thought to be something that if you are well enough to be coming to the hospital for services, then you should be well enough to do outpatient PT. And so it doesn't always guarantee PT services in the home. So I'm looking at this model a little different for her because of the concept of it being so much work to get to PT and such.
Right. Okay. So I'm sorry, did someone say something? Yes, Ms. Jasmine.
Thank you. I have a question. So does she have Medicaid insurance?
So she has private insurance at this point.
Okay. So please feel free to correct me if I'm wrong. It sounds like a lot of what she needs to get settled in the home could be taken care of possibly under an insurance generally. It brings us back to like our earlier meetings where it seems like the barrier would be finding an agency that is willing to provide care for pediatrics in the home. And then possibly, because palliative is not a benefit, services like maybe if she was into arts or music therapy, those things may not be paid for. So it sounds like overall, the majority of the services for palliative could still be rendered, but the main thing would be getting staff in the home to help care for her and make her comfortable. That seems to be the major barrier that we're seeing.
I think it's fair to say that that's the most obvious barrier to me, is that would be the most obvious barrier. I can tell you that that I'm on a text thread. I was trying to think of a text thread talking about DME and not being covered currently.
Right.
So yeah, so I'm having trouble accessing some DME stuff that I need.
So for commercial payers, I could see how that could be a bit different. So understandably, they may not do PT in the home, or DME may be a problem. So thank you, Barbara. I'll let you go.
Thanks, Jasmine. Dr. Moss, a question that I had, and maybe it was said, but I wrote down the payer and then location, because I've heard with the group that location matters. because there are
Absolutely.
some agencies that are open to helping to support. And again, this is a very, I am on the heels of finishing the report with Karen Mulvihill and the palliative care. And I looked at data, and now I know there are 14, I think it's 14, pediatric certified palliative care or hospice nurses in the state, which was startling for me. But I also know that even in the bigger picture outside of just pediatric, we have a really small workforce for expertise in palliative and hospice care. But getting back to my original question, location as well is what I've heard through our meetings may be a challenge or a barrier, because there are not a lot of agencies that have the capacity to help support not only hospice, but pediatric hospice. This is really a specialty area. And how does Dr. Moss and her team identify who can provide this service? Who has the capacity at any given time? I don't know the answer to that, but I think that's critical, because the longer it takes for you to identify an agency, the longer this individual may have to stay in the hospital and not be home where they need to be.
Right. Exactly. And so like where I go with that too is as we think of all the different things, right, that are, staffing being a huge one. And, we're trying to work on now becoming, like regional wants to become a center where we will train hospice nurses, pediatric hospice nurses. We're happy to start some kind of program that we are willing to train. And that means Fairfield County, a little bit of New Haven, a little bit of Litchfield, and we have gone into Hartford. But again, like we're saying, how do we get other agencies to provide pediatric care? And one thing that I wanted to ask you, Dr. Moss, while you're putting this, together in your head, that they're not ready for hospice and they're not. I sent out just recently, because I printed out the actual pilot that they did in California. And it's kind of hard for me to understand it all, because what it looks like to me is that they took away the criteria of 6 months or less for pediatric hospice. And do you think if that was gone, from having to tell a parent, we have to certify that your child is going to be dead in 6 months or less, if the disease took its natural course, but it's still hospice services because they may have a chronic illness. They may have an illness that if they weren't being treated, they would die. It just is fact, but we either called it something else or took that criteria away. Would it be a benefit to sign them onto a hospice-like program at this point?
So it's an interesting question, and I think the way that I can address it has two components to it. One is the 6 month, when the 6 month designation for hospice is actually more of a challenge sometimes for the provider, because people feel like kids are resilient, and you're looking in a looking glass that you don't have to say where the child will be in 6 months, and they could be here. Some of these more genetic based syndromes, I gave you a cancer scenario, I can give you a genetic scenario, right? A child that's born with a genetic condition. We live in this amazing age where we get these genetic panels that show us about a SNP, and it's the first kid in this area, and we can't prognosticate, but we know they're losing milestones. We know they need medications. We know they need support. So it's hard to suggest a hospice designation not knowing the life course of the patient. So that can be hard from the provider standpoint. So getting rid of the 6 month allows providers to say, I'm unclear, but this child certainly has life limitations based upon this disease. And although I can't speak to the prognosis specifically, this child, is in a hospice model, needs a hospice model of care. Secondly, the discussion with families, we generally don't talk to the families about the 6 month designation. It's not the family saying you're prognosticating 6 months. It's the misunderstanding that hospice is end of life. It's the misconception that if we enroll your child in hospice, that we are giving up curative therapy options. We are giving up hope because we were moving to an end of life model, because hospice in the United States still stands for end of life care for people, right? And that is a vernacular thing that those of us who love hospice feel sells hospice short. But that is probably the greater reality, is the families, just the concept of hospice. So I think if it's merged into a palliative / hospice together, where it, but yet they're much more fluid in the offering for people, I think that's where we get the responsive families and accepting the designation to that. Right? We're enrolling you in palliative and hospice services. The state of Connecticut offers this much support. By doing this, we will be able to get more services in your home. Right? It's not a prognostication thing for you. It's more of a support service opportunity for you.
Right.
Can I just ask a question? If you were to remove the word hospice from the dialogue with families, I mean, you all know what hospice is and the value that it brings, but if you were to remove the word hospice, would that change parental involvement or encouragement or anything like that?
Well, I guess that question becomes a question of what does that look like? Meaning, like, when we present it, we say you're going to get these support services, but if I say I'm, regional hospice is coming to your house tomorrow, the only word they hear is hospice, right?
Yeah.
It really changes a lot and it says hospice in billing documents. It's utilized, so it's not so much that removing the word in the initial conversation would add benefit, because then you have to remove the word consistently. And we love hospice. Hospice is incredible and has such opportunities for patients and families. We just have limitations in families accepting hospice at the time when it may be most appropriate for us to begin that process. And so palliative care starts way before hospice does for most of these patients. And what we're looking at here as a state is how we provide better services, no matter what we call it.
Okay. Thank you.
Does that make sense? I hope that.
Yeah, no, of course. And I certainly understand why, the importance of hospice. So I have no pushback from me on that. I think it's just, I was just kind of, brainstorming what if, but I think there's a value to bringing that into the conversation. So.
Absolutely.
Right.
Barbara, I saw you had your hand up. I wanted to not ignore you.
It's a legacy hand, actually, Dr. Moss. But what I think I heard were 3 recommendations that we should at least discuss for consideration in the report. And Tony Ann, I think your suggestion about, and I'm making this up, but a center of excellence for training, so that we can expand the workforce. And again, it was startling for me as a non-hospice, non-palliative care certified nurse to see the numbers in Connecticut. And then the second was related to developing some kind of I don't know what we would call it, but a mapping system, so that when Dr. Moss is looking for a home care agency that provides palliative care, a mechanism to help her identify that. And the third is and again, to your thoughts, Melissa, somehow reframing the conversation about palliative care versus hospice certification and the disconnect in services there. That to me sounds like and not to be bossy, but a third recommendation as well. That really, it sounds like Dr. Moss would help your situation and help this 15-year-old who needs to get home.
Yeah, totally. Like you just like summarized the whole thing right there, right? And if we're like, Melissa and I were talking about it yesterday, like where you can see on, I can't remember, Melissa, I think it's page 7, but in her PowerPoint, I think it's page 7, where it's challenge number 4, where it says about Connecticut Champion Care, Children's Health Advocacy Management and Palliative Care. If we were able to write our own, have a clean slate right now and how we wanted to provide this, maybe that's what it is. Maybe it's called Champion Care. A hospice that provides pediatric hospice should also, provide champion care that maybe moves into a hospice model at end of life, but is still providing all of those services to that family before they're ready to have that conversation, before the provider is ready to commit to, a 6-month prognosis. We call it something else. And yet we provide all those services and allow those services to be provided at once. If they need a model like this, we could provide what we provide right now at hospice, provided through this champion care, let's say. That would give them 2 to 3 visits a day. If not, they would need, if not, they needed more. A social work, some kind of chaplain care. It would provide 24/7 nursing available to them overnight. And could they then at the same time, and DME, right? DME becomes ours, pharmacy. And could we also get it where if they needed additional nursing, they could still get nursing in the home? And while we're talking about who's providing, pediatric care and who isn't, to me, any hospice that is of a certain size should be held to provide hospice from age 0 to 100 and whatever. And, and I've been talking with the folks at Day Kimball, and I can't remember her name because she left now. Her name is out of my head. And she said to me, I would love nothing more than to help this. I would love nothing more than to provide pediatric hospice. Their average daily census is 26 for adults. And how am I going to train my nurses? So that's a hospice that you might say, okay, with an average daily census of 26, and you have about 5 nurses, if you're lucky, we wouldn't expect that they would be able to take on pediatric hospice there. But these hospices that have a decent number of nurses and over 100 adults in the community should be held to doing pediatric hospice. And there's home care agencies that don't do complex pediatrics either. They do the sprain my ankle, I'm at home, we give them PT, blah, blah, blah. They're going to get, discharged in 2 months or whatever, but they do not want to touch complex children in the home. So those are the things I'm trying to think of with the idea of, we may be regional hospice, but we also provide champion care, which is, the children's health advocacy, whatever it was that Melissa came up with, that can eventually, provide you with all this care and support and will lead right into end of life if your child gets to that point. And you can have home care. I mean, that's kind of where I don't know, I don't want to say a delusion of grandeur, but that's what I think we should be building. And Medicaid, private insurances should be following Medicaid and Medicare. I mean, we have Medicare, and like I've said, I have private insurers that pay less than Medicare. They should have to pay at the same rate that Medicare pays. We should be providing all of these things. We're not asking it, we're not asking for the general population and all adults and everything. We're asking for kids, from birth to, I know it goes to 21, even if we had to cut it off at 18, which I hate to even say, but that's what we're asking. That's what we're asking for. We need to change it because we're not providing it. And that's one of the things I think we need to change.
Thanks, Tony. And Regina, do you want to weigh in?
Yes, so so my question is, for the model that we're building, can we just then call it, for the purposes of pediatric care or services, can we just call it palliative and or hospice, care for pediatrics? Instead of just having hospice services for pediatrics, can we combine the two and call it palliative and or hospice care for pediatrics? And my second question is, with the case in point, the case that we're discussing, I know that the insurance is private, but can they have Medicaid once their private insurance runs out?
They can have Medicaid as a secondary, and this patient does not happen to at this point. They get to a point where they've in their care where they become eligible for that. So she does not have Medicaid. I should double check and make sure, but I don't think I'd be on all these text threads today about DME if there was an option for putting it through Medicaid. So yes, they can have Medicaid as a secondary insurance at a certain point.
At a certain point, meaning
there's a certain financial point where they bend over into it. And I don't know that I think I'd have to have someone else on the insurance side speak to that, but I'm just double checking why we're talking, but I don't think that she is secondary. So right now we're looking at, well, I'm sure she doesn't because of the questions I'm fielding about home care pieces of equipment for her. And DME is not generally, I just want to be clear. I brought that up because that's the case that I'm actually working on right now. But I can give you a whole host of other cases where DME went through and we just didn't have an option for an agency in the home to help with nursing. And this child happens to live in an area where it's not easily covered and there's not someone, and as Tony alluded to, some of these groups go in and they do, immunizations, or they can do diabetes management, or they can do even home chemotherapy, but they can't do palliative and hospice support services for families. So we continue with the limitation. I do like, Barbara, the things that you listed out, the three, the way you were hearing it. I do think I think the mapping system is something we should really think about, how we do a blueprint for critical illness for children, and what that looks like. Courageous Parents Network has done all that beautiful work with NeuroJourney and other ways of mapping illness. And I think the thought of us developing a statewide illness mapping opportunity for families would be incredibly helpful, because it would just embed all the resources that are available to them at different times as they progress through. Because, unlike with adult hospice, where generally patients qualify for adult hospice based on acuity change towards end of life, children can qualify for support services akin to hospice when they're born with a genetic condition like trisomy 13. Now, patients with trisomy 13 can live for a very long time, depending on if they have a predisposition syndrome and develop cancer, they may not, or if they have a cardiac condition as part of their trisomy 13, right? It just depends. But those little humans can benefit from these support services from the moment they're even prenatally, when we know they're coming. And so it's such a different lens we look through when we think about how to provide services for this population when we look at children versus adults. And I think some of our task is just to reframe what that looks like for people within our state, understanding that these are not, they're not the same playing field.
Just having come from a previous life in corporate America, I understand when you start out something new, how difficult it is. I think it's important. I think Barbara is setting out a vision for what you think the right solution is a starting point. Obviously, the devil's in the details. And so there's huge challenges getting through some of the things in terms of maybe the sources for payment, or the resources available, or the training pieces. But all those are kind of, I won't say secondary. Those are the things you have to map along the way and manage along the way. But I think if you were all asked what's the right way we should handle this, coming up with a model for this, you want to put it out there. My version in life is always, if you want 3 cookies, you ask for 5. You kind of push the envelope and you ask for what you think is the right solution, and then kind of figure out from there how to get there. Because if you don't shoot for the moon, you get probably, something along the highway along the way or something. So I think you guys have incredible ideas on, what's necessary and what's needed. in order to serve, the pediatric population.
So, Melissa, I love the way you branded this, though. And that's really one of the first steps is branding and the concept of champion care. I mean, I love that model. And then everything that we've discussed gets tucked neatly into that brand. So love the concept of CHAMPS, that acronym. It's great. And that the children receiving services. Were you in marketing? Is that where you worked in corporate
No,
America?
but I spent a lot of
great.
time creating programs and trying to sell them to our population. So there's a lot of hand-holding and one-off and individual selling you have to do when you're trying to move something forward, an initiative forward. So I did a lot of that in my career.
Well, that brand I love, the champion care. I think it's great. And I think DSS can piggyback onto that nomenclature. It's just pitchy and, I don't know, motivating.
Yeah, and I don't want anybody to
do
think you have to go with that, because that was just a stab I took at creating something just to have it, having some sort of nomenclature just to position it. But, there might be others out there with much better ideas. I just thought I'd throw something out there just to give people a sense as to how do you reframe something that's really critical and crucial in a way that may have broader application for the general public.
Yeah, I agree. I like it. It was a great first shot at it. I didn't get a chance to read what you sent, but I'm wondering if we've like specified what services would fall under palliative also. Because while it's very close to hospice, there's just some things that probably won't be appropriate under palliative that would be, under palliative that would be appropriate under hospice. So I think it's also important for us to kind of detail what that looks like too. What are we expecting to see? What kind of services are we expecting to be rendered? Because if we just, come to parents and we're saying, comfort measures only or palliative, it still feels hospice-y.
Right.
And we want to be sure that there is a distinction. While it's similar, there's a distinction.
I would imagine too, there are right now decisions, like right now it's palliative. 3 weeks from now, it could be hospice. So it may be, it's a judgment call on the part of the medical providers to help families understand, what they need and when.
And here's the weird thing for us, right? For us, meaning, we provide hospice to adults and pediatrics. So for us, when we go into a home with an adult, we already know there are no life-saving measures being taken. There are no interventions being taken. We are usually even switching from seizure medication, something on the formulary that works, but is, might be less expensive. And we're, talking about, do we really need blood thinners? And, what would that look like? And blah, blah, blah. When we walk into the home of a pediatric patient, we're looking at it from a perspective of they may still be having radiation, chemotherapy, any kind of intervention. And we are just looking, how do we support this family through this process right now? And, at some point, we're going to have to help prepare them and carry them through the journey of end of life. But when we enter that home, we're entering it from, unless we get the child, in the last week of life or something, which very rarely happens. We're usually getting them and they still have some kind of intervention going on, or, some life-saving measures that they're going to try, or, things like that. So we don't always enter that home as hospice. We are hospice, but we're not treating it like a hospice case where we would an adult, where we're going right to, this is end of life. We want you to have the best quality you can, but this is true hospice. And I know exactly what you're saying, Jasmine, like what falls under palliative and what falls under traditional hospice. But like in Washington, when I read their thing, they did some kind of merge where palliative has fallen under hospice, so that you can get palliative care. They can call it palliative, but it's almost as much as what we provide from hospice. So like, how do we do something like that? Or again, because I'm just loving this, champion care thing. How do we call it something that could be the same kind of service as hospice, and then it progresses as the child progresses? But you could still be able to provide it with just by having a hospice license.
So, Tonia, that brings me back to the question I asked earlier, which I don't think was answered. My question was, is it then right to say that we can combine the two under this champion care or champion model that you are
Yeah, that
proposing?
would be, I would say yes. Like, I would think that that would be something that we would look to pursue.
Right. Would we be combining, or would we just be creating a smooth transition between the two?
I think we'd be creating. I mean, if we're gonna, we're given a clean slate here, I think we would be creating, and at worst case scenario, maybe they come back and say, well, the best we can do is you combine it somehow, or, whatever. But I think it's creating new along, creating something different, but that you can provide it if you're licensed for home care, which, we're licensed for hospice in our center, we're licensed for home care.
Right. Yeah. It's just like, it's similar to hospice, but
Right.
very person-centered, not focusing on end of life. So yeah, I think we would be starting something new by doing almost like a warm handoff,
Mhm.
bringing two services that are similar. One's a covered benefit, one's not, and kind of seeing patients from one end to another.
You got it, Jasmine. Now go sell that.
Find the nurses to provide it.
I need
She'll be the
some courses.
spokesperson.
I need courses in marketing from you.
Doesn't sound like you need the course. Sounds like you've already done it.
Right. And that would be, that would be part of that. Now we have this service, and how do we now go out to, and maybe it's not just working with one university. How do we have a couple of universities that are providing nursing programs and make pediatric care, whether it's, palliative or end of life, part of their rotation? It's part of nursing care. People may not go into it, but they need to get a taste of it.
That may also go back to Dr. Moss's comment about having a mapping system, so that if certain resources may not be directly available in that particular area or something, there could be people you could draw upon, so that the services are available. They may not be tied directly to that facility, but they're going to be there.
Right. And then add in, because I loved what, I'm so horrible with names, but I love who spoke to us from Massachusetts. I can't remember
Gary
her name.
also?
Yeah. So she spoke about how much money is funded in Massachusetts, and they're just providing this care from state funding. They're not even worrying about insurance. Like, they're providing care for their pediatrics because they're being funded by the state. And that's what and they're just a combined, I feel like they're a combined entity with 10 different spokes off the wheel that provide the care across the state.
I love what they did, of what they're doing and how it's grown. The only thing is that we want it to be sustainable.
Right.
So could I take a couple of steps back? And I heard that there's discussion about combining the concepts, not combining yet, creating a concept of hospice and palliative. And it makes me pause. Are there any, and for a good reason, are there any regulatory barriers that we need to look at in order to do that. And I don't know the answer to that, but I can explore that. But part two of my comment is I just left a meeting 45 minutes ago where we are looking at revising the home care and hospice regulations. So is there anything that I need to take back to that group that will mitigate or support transition from palliative to hospice that I can do as homework? And then my second comment would be, would it be helpful, and I think I can do this at DPH, if we mapped out, actually literally mapped out all of the home care agencies in the state and mapped out the hospice agencies in the state, just as a starting point to have geographical context. So I could take those two homework assignments. But are there any barriers that jump out to any of you who live and breathe this every day that I can take back to this group that would be a roadblock for us on the DPH regulatory side? I don't know if there's any payment rules for that I'm not an expert.
Yeah, that's the whole thing with the criteria, but from a DPH perspective,
And I'll poke at this on my own with our team here at DPH, but is there anything that the timing is perfect because we're rewriting the regulation?
I would like to know one thing from a DPH perspective is if an agency was to agree to even do, like, let's say palliative, which, you need your home care, right? But we don't want to provide traditional home care to adults. We only want to be able to provide it to children if we were to then move them from palliative to hospice. But I don't want to go like home care, doing the OASIS, like providing traditional home care and having to be held to the OASIS. That's something I would not want to be involved in. I'll leave that to the home care agencies that do traditional home care. But if we're able to bring on children from a palliative perspective and provide that through our home care license, but only for pediatrics, because that's what holds me back from moving forward, like in going into the home for kids from a home care perspective, is I would have to be dealing with OASIS on the adult side.
And so,
do you know what I'm saying?
The OASIS having to, and this is a question, it's having to do an OASIS assessment, which is a federal requirement,
right?
For a pediatric palliative patient is a barrier?
No, but if we are going to provide that service, can I only provide it to pediatrics? Because if we do, we don't have to do OASIS. Like, is Medicare going to say to me, you have to provide it then to the general population, not just to pediatrics?
Let me follow up on that.
Okay.
All right.
They may make it across the board. That's kind of what I'm thinking.
Yeah.
So that's what I was going to say. I almost lost my train of thought, was that as we're thinking about recruitment in a sense, like schools, we can try to recruit with nurses who are already working with peds, just not the hospice component. So they're halfway there. Or they may have experienced it a little bit. So like NICU, doctor's offices, they have the staff, hospitals on the units. So those nurses who are halfway in.
Right.
Got to bring them the rest of the way to palliative.
Absolutely. And then, giving them the opportunity to do it as a rotation, just like they have to go through labor and delivery or, something else. Because sometimes when they get a peek of something, they're like, oh, you know what? I do like that. Like, maybe that's something I want to be interested in, but we don't have anything like that for pediatric hospice or palliative. I mean, for me, palliative usually always turns into hospice, at some point, but being this, having the ability to provide the service, then train to fill the staff for the service, that has to go hand in hand. All right, I'm exhausted.
I know, just
What would you
it's a
need,
lot to think
Tony Ann?
about.
What would you need,
Barb?
Tony Ann, at Western to create a center for training excellence?
What do we need, like at regional?
Yes, if you were going to take on this workload, what
Well,
would you
I
need?
would need, no, I have that. I would need nurses to train.
That's all you'd need.
I mean,
an auditor.
you know,
You'd need students.
I have 2 palliative care. I'm sorry. I have 2 pediatric nurses, 1 pediatric, certified in hospice and palliative care. I have 1 pediatric nurse that is just trained by experience, but she's getting certified in hospice and palliative care. I have, a PhD APRN in the center who has done pediatrics that could teach. And I have nurses that love to teach. Like even just shadow, it's
Do
I
you
mean,
all,
as it would grow, we'd probably need, like, I'm working with Sacred Heart, Fairfield University. And so it's possible that the first semester that we do this, we're only going to have 2 nurses that are interested. And that's fine. But, if we start opening it up to more, eventually we may have to grow with the amount of nurses that would be rotating through. But right now, we could take 2, 3, 4 nurses to teach.
And is it teaching that could be done? I'm just trying to think about pathways to certification, to the official certification. You need, is it 3,000 hours? I can't remember what it is. You need,
Yeah, I'm
there's
not
a
sure.
floor of hours that you need to sit for the certification exam.
Right.
Would that be a pathway to that certification?
Yes. Because remember, at least with Fairfield University, I'm sure it would have to be the same. We're providing the rotation and the education through the rotation. We're not providing classroom time.
Okay, got it. Got it.
So it's like a regular
It's a
rotation.
practicum.
Right.
but so Tony, as far as being like a center of excellence, that would be with you, correct?
Correct.
And you already have curriculum
Well,
already.
that would have to be like, that's in tandem. We'd have to develop that with, set up, what does the rotation look like?
Yeah.
And the university would actually be doing the academic part of it, and we're doing the shadowing and the teaching, like the on the patient teaching, like like if they went into labor and delivery and they're at a hospital, they would be here doing pediatric hospice.
Okay, that sounds good.
And then, like Senator Anwar has said, how do we get them, how do we teach them and then get them to stay and work in the state of Connecticut for a year or 2? Like, is there incentives we can provide? Because there are so few that do it now. I mean, I would love that just they get a taste of it and somehow they fall in love with it, but an incentive to get a percentage of your loan paid off if you stay in it for 2 years here.
And workforce strategy is working on those mechanisms and levers with Bernie Price and Billy Wang. Those are hopefully aspirational things that they have success with.
Right.
Yes.
But Barbara, I was going to say that because you say you were on that one as well. Like that work group.
In the beginning, yep, I was.
Yeah.
Yes.
And so it seemed more so like they had the same goal, but there was no incentive for the students other than maybe more access and support while in school. And then the school received funds. So I think what you said, Tony and Senator Anwar, that's going to be important to try to develop an incentive for the same way that providers get it for going to FQHCs.
Exactly.
developing
That
some,
may be a model, Jasmine, to mirror.
yeah. Well, it's on a federal level, I believe, so
Yeah.
we'd have to look at that.
We still have to think about like when they're done with that training, how that translates to the job force, right? And what that looks like. Because right, if you're a nurse who comes and loves that, but then ends up with a job at Connecticut Children's or Yale, how do we get you so you're able to do some of the pediatric hospice? So I do think there's some bigger leaps after. I mean, this is starting, but bigger leaps. How do we develop the relationship where you can be is there a way that you can be a Connecticut children's nurse and also do some pediatric hospice as part of your job? Like, how does that work?
I'm wondering if that's part of the mapping system that you know where people are and where, and I think too, Barbara was going to look into what resources are out there. I mean, it's sort of a job placement situation almost.
Right. Exactly.
Right. I do think we need to think about, though, as young nurses, like it would be hard to do pediatric palliative care and exclusion. I don't know if others have that sense, but we know it's hard to do just pediatric hospice or palliative care as your first job. And I think we need to be open to how there's combined opportunities, just because the emotional bandwidth that it requires to maintain in this is sometimes hard for a brand new nurse. If we're talking about someone looking for some loan forgiveness right out of school, then we need to make sure that this job meets their needs fully. Does that make sense? That we don't burn them out
Absolutely.
quickly because it's their first job and they lose 3 patients and then they're like, wait a minute, am I a nurse? Why do I want to do any of this? Right. There has to be some sensitivity to how that implements for sustainability purposes.
Exactly.
But that's a good problem to have the trained people and figure out how to best utilize them would be a good problem. Is a very different problem than the one we stand with right now, which is not having the trained nurses and or the opportunity for utilization. So
were we, and I may have dreamt this because that's very possible, did we talk about at any point trying to figure out how many kids there are in the state of Connecticut who are terminally ill or chronically ill that do not use any type of services, that don't have palliative care, that don't have hospice? Again, I think we were down to 5. We just admitted our 6th today. And I know we're only one area of the state, but can we give an estimate or data on if we were providing care, this is how many kids we could help?
So I think Jasmine and I were going to look into that at our last meeting, the last time we met, and we've already reached out to the Katie Beckett program, and we have a meeting with them tomorrow to look at the data. So we'll get back to you on that.
Okay, thank you so much.
Does the Katie Beckett data include those that are on the wait list for informational purposes?
We'll try and see. I'm pretty sure they do have the data, it's just whether or not we can stratify it. And then also, so it would be a partial answer to your question, because then there will be kids who are on the list who are getting services, and then the ones off of the list or on the waiting, the ones who are actually in the program who are getting services somewhat, not necessarily maybe palliative, we can ask that, but then the ones that are on the waiting list, they wouldn't be getting any services, theoretically. But we don't know that because everyone on the Katie Beckett waiver comes from different socioeconomic statuses. So some families may be able to provide some type of care in the home, may have another insurance. So these are questions that we'll bring to our internal discussion tomorrow. If you guys have any additional questions you'd like us to ask, please let us know.
Yeah, for informational purposes, I know that there's about 500 kids on the waiting list for Katie Beckett. Is that all right? Is that about the average?
I'm not sure. I wouldn't be surprised. Yeah, I wouldn't be surprised, but I'm not exactly sure how many there are. I believe I said more than 300.
I had a patient tell me yesterday they were 455 and 456 for their 2 children. So that was where my 500 came from.
So there,
Wow.
yeah, you're close.
What
They have
is,
2 dogs.
you guys will have to educate, but what is that?
Oh, the Katie Beckett waiver.
Yeah,
So it's a benefit under Medicaid where families who have a child who's critically ill or terminally ill can enroll and get Medicaid coverage. So they may not traditionally qualify. And so it's a wide range of socioeconomic status and income. And
okay.
it's been really helpful for individuals and families around Connecticut.
Do we
And-
know how children and families get connected to Katie Beckett? So, for example, is there a possibility that there are children in Tony Ann's universe that may not have been connected to Katie Beckett, the waiver program, for a variety of reasons, knowledge deficits, or perhaps pediatricians have not connected them, for whatever reason. But I would presume that there are, and I'm not suggesting it's hundreds, but that there are kids out there that just have not been connected to services, and they arrive at Children's or at the ED at Yale with some kind of overwhelming issue, and then maybe get connected there, or maybe not.
Yeah, absolutely. I think there's always that possibility, like that we have so many services. How can one individual know what? I mean, sometimes we don't even know about all of the
Yes.
services, and we have to call on each other. And
Yeah.
so as a provider, like even when I'm meeting, a lot of patients don't even know that they're patients in my setting. They don't even know that they can get NEMT, like free transportation, non-emergent. So I'm probably certain that there are people out there who, I don't know how many, but people out there who don't know about these benefits. I mean, look at us. We're on this call doing this work. And Tony's leading us, and she's never heard about it before. So she can pass this on now.
Are there, I'm assuming there's numbers of children out there who are getting support through private insurance too, their parents have it through their employers. Do we know the numbers on that? Because I would imagine services in our turn focus on not just the payer basis, but really more the services that they need and the support they need. So do we know, is there any way to find out how many kids are out there who need pediatric hospice services but aren't going through a public source?
I'm not sure. I wonder if OHS would know that, maybe. They work more closely with commercial payers and hospitals. That's a good question.
I mean, if you're saying there could be upwards of 500 through the Katie Beckett waiver system, there could be equal numbers who are getting support through private insurances. You could have 1,000 kids out there who need the services that are going to be provided through some sort of program that are palliative and hospice related.
And the system is, as Jasmine has indicated, and I would loudly concur, is difficult to navigate. So,
Yes.
and these are here Jasmine says she is unaware of some supports that are out there, and I'm unaware of lots of supports that are out there. So it's complicated. I think though, when you get ready to prepare the report, I think, and just from my past experience with preparing work group reports, data is very helpful. It
Right.
helps the reader understand the context of the situation. Is it one child who's been affected by this? Or when I hear 500, maybe on the Katie Beckett waiver, that's a large number. I know just from my own personal awareness, do we even know, did we ever establish how many home care hospice agencies even have the bandwidth to care for a pediatric palliative patient? Do we have those numbers? Because that will be helpful. I think we're going to want to give the legislators context that we have, and this number is a hard number, we have 88 home care agencies. Of that 88, making this number up, 5 have capacity, skill and capacity to support pediatric, palliative, or hospice care.
Yeah, that's good. That is good information to have because, as you said, I've been told the same thing. Data's important. You know, and when you're trying to build something, okay, well, we're going to build it and it's going to make it easier for 10 more kids to get service, or it's going to make it easier so that we can put on 500 more kids that should
Yes.
be, you know, having these resources and services in the home.
It will inform decision making. It will.
Yeah, so that'll be key to know, like how many terminally ill or chronically ill kids there are in the state of Connecticut that could be benefiting from these services if, go ahead.
I just had this realization. I wonder, Tony Ann and Dr. Moss, you may remember the researcher at Yale that we are going to, with our Palliative Care Advisory Council, we're going to do some outreach to him on the Palliative Care Advisory Council side. I wonder if he has any data that he could share that would be useful. And forgive me, I don't even read. This is terrible. I can look in my notes.
His name
I
is
remember,
Eugene.
yeah, I can't
Eugene, yes.
remember.
Yes.
Who is it, Carrie?
Eugene is his
Yes.
first name.
Yes, yes, yes.
And I could also send out a survey to the licensed home care agencies and licensed hospice agencies if you think there's value in that through the Outlook system. I've done a fair amount of those surveys now for CMS, and they've had some utility.
That would be great. I think it would be helpful.
I think if we're going to survey about pediatric cases, I think we have to ask not do you provide pediatric hospice or pediatric home care? I think it has to be, if it's home care, when was the last time you actually treated a complex pediatric case or chronically ill, and how many in the last year? Because there have been, and Carrie and I have done this in the past, where we just have cold called agencies that will say they take care of pediatrics, and home care agencies that say they also do hospice home care, which causes then the issue of another hospice coming in. And when you call to say you have a case, are they willing to take it? The answer is no. So some of them say they do it, but they really don't.
So why don't I do a survey draft? I'll send it to this group, and for your consideration and input. I'll start out with a few questions, and then we can build on it. And then maybe, now you have an extension till March for the report. Is that my
Yes.
memory, or am I confusing it with another work group I'm on?
We have till March.
Okay. So I'll get something to everyone next week and just add to it. But I'll start something, and this way we'll have some data, and maybe
Okay.
Eugene, they're a real data mining bank. They have real credible data.
Yeah.
So I think he
Okay.
could be helpful.
I think it would be interesting too, and I'm happy to take this on, is to find out when Washington and when California did these pilot programs, how many more kids benefited from the changes of no longer calling it hospice and making it something else, or making palliative care come under hospice. How did that open up pathways for them?
Can you repeat that, Tony Ann?
Yeah, how, like in California, where they piloted a model where they took away the criteria of 6 months or less. You're coming on hospice, we're going to certify that you are, 6 months or less is your prognosis.
Got it.
How did that help families or providers sign kids up for that, taking that away?
And you're suggesting we ask that on the survey?
Yeah, I mean,
Okay.
I can, and
Okay.
I'm,
Yep.
I'm happy to work on that too. I'm not sure how, but I can figure it out. I just think it's good to say, well, they tried it here. Well, that's
Yes.
great. We know they tried it, but were they successful?
Okay.
Does everybody on this call feel that maybe we could meet again in the month of January? Like maybe the last week in January, just to maybe bring up again the things we're talking about to come back with, because I feel like March is around the corner. And I don't know if it's like the beginning of March or the end of March that these things are due, but it's kind of close. I can send out some possibilities for another, meeting and see if we can just nail down some of these things we talked about today.
Okay, maybe, yeah, we can circulate some dates and see what works.
Perfect.
Want to try and do an in-person before this is all said and done?
I would love nothing more than that. I love to meet in person. And we had thought Peter had gotten us where you can see Karen sitting there. So we have the space if we need it, and if that's, a good spot for everyone, or is there a different, I don't know where everyone is located. I'll go anywhere, because I'm pretty much, I think I'm furthest from everybody. So I'm happy to go anywhere.
I am as well. I can be flexible.
Dr. Morse, where are you? You're in Hartford?
I'm in Hartford.
You're in
Most days.
Hartford. Okay.
So the closer Hartford, the better, just from a clinical care standpoint. But
Yeah, of course.
I'm always able to find space at DPH. And depending on the time of day, parking may be better than times day. But they're not modern plush accommodations, but we have space that I can find.
Yeah, that would be great. Okay, so how about we'll send out like a poll for days. We'll send out some days and times and places that might be good for everybody to. Jasmine, you and Regina, where are you both?
We're in Hartford.
You're okay. So I think
Um,
Hartford. Can you guys hang on 1 second? Because a patient's room is calling me. They hung up. Must have realized the wrong number. Okay, so then I think Hartford is the best place for us to go to. Okay, so we will send something around then and do a survey. I'm trying to just look on here. Oh, the CTN account. Now I know what that is. Okay. So Karen, you and it's Brian. Brian is there with you, right? I think that's what I heard him say.
Yeah, it's Karen and Brian.
Are you guys, is Hartford, I mean, clearly it was good for you both today. Again, I'm so sorry for that, but is that the best place for you both?
They both say yes.
Okay.
We
Okay.
make the 29th work, which is 3 weeks from today.
I could do the 29th.
29.
Others?
Do you have a time on the 29th? I have a board meeting that day at 5:30, so I don't know if you'd want to do the same time. Oh, maybe I could make it back though by 5:30.
Sorry. FYI, so after 3 on Mondays, I'm not available.
You're breaking. You can hear you.
Oh,
We lost you, Jazz.
Can you repeat that, Jasmine?
I think I heard Jasmine say after 3 o'clock on Mondays, she's not available.
Oh, okay. All right, so the 29th is a Wednesday. So can most meet on the 29th?
I can.
Okay.
I'd like to just note that that the Connecticut General Assembly session is in like full roll, so it's going to be a lot harder to secure like meeting rooms and like dates. So we'll have to work on that a lot more collaboratively.
Okay, or we can maybe, Barb, if you could get us a spot where you are, maybe we could just go there. Perfect.
And I have my afternoon, I can usually move stuff around, but I have a 1 o'clock and a 3 o'clock on the 29th that I can't, they're with the commissioner. I can't move those around.
Sorry. So Tuesday, Wednesday, and Thursday after 5. Well, Tuesday, Wednesday, Thursday, Friday after 5, I can't typically meet. So it will have to be before that.
Okay, so it looks like I can, if I can move my board meeting, this is important that we get it on, so. Barb, is your 3 o'clock meeting an hour?
An hour, 3:50. Yes.
So Carrie, are you good for a later meeting or,
I can do later.
I mean, like, we wouldn't be able to do 3 because Barbara's not available.
What time? See, I don't know if we actually need 2 hours full. It's 2 hours is a
Oh, yeah,
lot.
I don't think we need 2 hours, yeah.
I'd rather meet more frequently and not meet over 2-hour periods. It just feels very long.
Yeah,
So Barbara, you're free at 4?
Yes, I can be free at 4.
Like, could we do a 4 to 5, but that's not going to get you back to your board meeting in time.
I can make adjustments there. They can talk about other things until I get here.
But can we do earlier than that also on that Wednesday? Maybe after 1, if it's not 2 hours, maybe can we do 1:30 to 2:30 or 1:30 to 2:45?
Sure.
I have a 1 to 2, but I'll not
Can
go
we
to that.
do,
Since
can we
important,
do
no,
a
I
2 to
can work at
3?
1. I'll work around 1 o'clock if that's going to be what everybody needs. I can be flexible there if I need to be.
Okay, can everybody do 1 o'clock then? And that's Karen and Brian too. Did we lose them?
That works for me.
Oh, there they are. Okay, perfect. Okay.
Okay,
So
I have
I will find space for us on the 29th, 1 to 2. If I could just get the names of, I'll send out an invite, but if I could get the names of the individuals that can attend, I will give them to security. They will check you in, give you a name badge, and then direct you to where
Okay.
the meeting will be.
Okay, perfect. So I will, and I'm also gonna reach out to Ross and Stephanie if they can join that day, and I can let you know, if they can.
So I have a quick question about the PowerPoint that was sent earlier.
Uh-huh.
Are we working off of this PowerPoint? Is it a draft we are working,
Oh,
we are
yeah,
going
this
to
was,
add to, or,
this was just putting together the items that have come up to date at all of our meetings. So we
Okay.
would be working on something separate to actually present in some way, shape, or form.
okay.
Yeah. Okay, so 1 o'clock on Wednesday, the 29th, and then we'll just wait, Barb. Well, no, I could put the address and everything down, right? You just need the names of who would be coming.
The names, and I'll find some office space, some meeting
Perfect.
space.
All right, sounds great.
Okay.
Okay, we good to adjourn?
I
Motion to
appreciate you letting
adjourn.
me join you guys.
Nice job, Melissa. Very nice
Well,
work.
thank you.
Yes,
No,
thank you.
I